कर सकते हो।
Let's start, Dr. Varsha.
Good evening, everyone. A warm welcome to today's ISI National PG online classes. I am Dr. Varsha, Senior Resident at Karnataka Institute of Medical Sciences, Hubballi, will be screen coordinator for today's class. On this special day, I have a quotation. Doctor is not a profession, responsibility, a great responsibility of saving lives, a noble value that provides priceless service. Doctor is a passion, doctor is the last hope of life. By quoting this, we, ISI body, wishes you happy Doctors Day to all the doctors around for all their hard work, courage, sacrifice, kindness in spreading humanity to the society. As a custom, before we start the class, let us evoke the blessings from Ma Saraswati. Today, we have a very important class on pain and pain pathways. The management of pain requires a good understanding of physics, of basics such as types of pain and pain pathway, ultrasound tools, and the with these few now I request our Honorary Secretary, ISI National, Dr. Sukhminderjeet Singh Bajwa sir, to throw some light on the topic.
Thank you, Varsha. Light will be thrown by Dr. Kavita Jana and team. But first of all, happy Doctors Day to everyone. My GC member is also sitting there, Dr. Sunil Sethi, and all the dignitaries and faculty students. I think a good day to start a class on a Doctor's Day. And definitely so many quotes coming right from the morning about the specialty, about what the doctors are doing to the humanity. So I think this is one another topic, the pain, relieving the pain physician, which has gained a popularity over the last 2 decades, especially with the advent of ultrasonography and all the new interventions of the invasive blockades, neural blockades. So many things are coming up, radio frequency ablations, and you name anything, and I think it's coming. And anesthesiologists are taking a lead in at least elevating the pain in all the fields. I think which was the domain of the different type of surgical field like ortho and others. Regarding it's the first series. I think pain pathways. It's important to understand how to go about it. What are the pain pathways? How the pain is really produced? How the pain is being carried by the receptors, and how they are being modulated, and how is it going to be managed? I think none other than Dr. Kavita Jan, ma'am. She's one of the senior most madam of the country. And she is of her own team. We will be very lucky to have this team today to throw the light on, real light on this pain pathways and the role of USG. It's a very difficult to concise this chapter this thing in a very, one and 1.5 hour lecture or and whatever demonstrations, but whatever the thing will be there, it is the beginning of pain classes also. So I request Varsha to start the proceedings from here. Varsha, I think,
Today,
not
we
audible.
have with us 3 eminent faculty to discuss this topic. Dr. Kavita Jain, ma'am. She is a moderator for today's class. She is a senior professor and HOD at the Department of Emergency Medicine. She was also ex-HOD of anesthesiology, affiliated with JLN Medical College with the 38 years of PG teaching experience. She has her special area of interest are acute management, cancer pain, and palliative care. She is a founder president of Ajmer Society of Pain, Ajmer. She is a fellow of Darada Institute, Kolkata. She has received certificate from the IAPC for palliative care. She is also coordinator of JLN Medical College for CTC program. She was the organizing secretary of ISACON 19 Ajmer. She was a past president of RSA 2019-21. Ma'am has received Indian Society of Anesthesiologists Proficiency Award 2021 for recognition of invaluable contribution and outstanding services from ISA. Ma'am has 13 national and international publications. Welcome you, ma'am.
Good evening, everybody.
Next, we have a speakers for today. Dr. Vikas Gupta, sir, is an assistant professor at the Department of Anesthesiology, affiliated with JLN Medical College, Ajmer, with 4 years of PG teaching experience. His special area of interest are acute and chronic pain management, cancer pain, and palliative care. Sir is a life member of ISA, ISSFP, and IMA. He is also a fellow of Darada Institute, Kolkata. He also has received a certificate from IAPC for palliative care. Sir has 5 national and international publications. Welcome you, sir. We have another speaker for today's session, Dr. Janu Boj Nagnal. He is an assistant professor at the Department of Emergency Medicine, affiliated with JLN Medical College, Ajmer, with 3 years of PG teaching experience. His special area of interest are emergency medicine and trauma and POCUS. Sir is a life member of ISA. He is a ATLS coordinator and ACLS and BLS instructor. Sir has 2 national and international publications. Welcome you, sir. Before we proceed with the class, there is a small announcement for the audience that all your mics will be muted during you can type your quotes all your after the session. These classes are also telecast on YouTube channel ISA NHQ. Now I request faculties to kindly introduce their PG and take the session further.
Varsha, am I supposed to introduce? Hello?
Yes, ma'am. Yes, ma'am. Please, ma'am.
Good evening, everybody, especially Dr. Bajwa, Madam Madhuri, Dr. Varsha. It is really a pleasure to be here on this platform for the topic which is of our favorite for everybody. And we shall be starting with our PPT. I have with myself Dr. Vikas, Dr. C.K. Sharma, and Dr. J.B. Nawal. Right? And the part of our presentation contains almost 2 parts, part A and part B. Part A is pain presentation, pain pathway. Second is the role of USG. Okay, in day-to-day anesthetic practice. So we shall be presenting in 4. We are totally 4 people. And off and on, we'll be asking questions also. Dr. Bajwa, should we start?
Ma'am, please start. Please go ahead, ma'am.
Dr. CK, you can start with your PPT.
Good evening, all, and happy Doctor's Day to all of you. Is my PPT visible?
Yes, it's visible.
Okay. So today I'll be presenting pain and pain pathway class. In this, we'll be overviewing definition, classification of pain, nociceptors, chemical mediators, and pain pathway. So pain. Let's start with the etymology of the pain. In Anglo-French, the word pain in English has its origin in Anglo-French word pain, which means pain or suffering. Latin, this term can be traced back to Latin word poena, which translates to penalty or punishment. The Latin term emphasizes the idea of pain as a form of retribution or consequences. And going further back, poena itself is derived from Greek word poine, which means payment, penalty, or recompense. This Greek origin underscores the concept of pain as something given in exchange for something else, often as a form of justice or balance. So, Joint Commission on Accreditation of Healthcare Organization, they have declared pain as the fifth vital sign in the year 1999. So, International Association for Study of Pain in the year 1979 defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So after 4 decades, in the year 2020, they revised the definition as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So basically, the key change in this inclusion was the experience and the resembling that associated with the tissue damage. This acknowledges that the pain can occur even when there is no clear evidence of tissue damage. For example, conditions like neuropathic pain or certain chronic pain syndromes, they can cause pain and that feels similar to pain caused by trauma, even if there is no such tissue damage. So in the broader scope, the new definition encompasses mainly on the pain experiences. And it also includes 6 keynotes. First keynote is the pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. It means that everyone feels pain differently, and it's unique to each person. And it can be varied by biological, psychological, social factors. And pain and nociceptions are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. It basically means that pain is basically what we feel and experience when something is hurting. And nociception is the process by which our nerves detect harmful stimuli and they send signals to the brain. So just because nerves are active, that is, there is nociception, it doesn't mean that the person is experiencing pain. Through their life experiences, individual can learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. And verbal description is only one of the several behaviors to express pain. It means that saying that something hurts is one way of expressing pain. And there can be other behaviors like actions like crying, moaning, or limping. And inability to communicate, just because someone or an animal cannot talk doesn't mean that they are not feeling pain. So they might show it in other ways, right? So these were the 6 keynotes. Now let's come to the classification. Based on the source, location, referral duration, it's divided into 2 parts, acute and chronic pain. Our main focus of area will be acute pain. So acute pain is further divided into visceral and somatic pain, and somatic pain is divided into superficial and deep pain. While chronic pain can be malignant or benign pain, and benign pain can be musculoskeletal pain or neuropathic pain. So pain and alarm. So it's true for acute pain, which is our friend, and chronic pain is a false alarm. It's a disease itself. I'll explain it in the coming slides. So in acute pain is also called as physiological pain. It's nociceptive in nature, and it is a symptom of disease. When we treat the disease, when we cure the disease, the pain itself limits. And there is a simple relationship between pain and tissue damage. That is, more the pain, more is the damage. Sorry, more the tissue damage, more is the pain. And it's proportionate to clinical findings and biological function and our friend. So what does biological function and our friend mean? It means the acute pain is a biological function acting as a warning sign to protect the body from further injury, and it prompts behavior that aid in healing and recovery. It can be considered as our friend because it helps us avoid further damage to the tissues and organs. Right? And on the other hand, chronic pain or pathological pain, it's nociceptive and neuropathic in nature. It's a disease in itself and a disease of nervous system. It's difficult to treat and sustaining. There is a dissociated relationship between pain and tissue damage, and disproportionate to the clinical finding, and it does not have any biological function. So according to Bonica 4th edition, pain has been defined as the injury of the body tissue and activation of nociceptor transducers at the site of local tissue damage, lasting for a relatively limited time until the pathology resolves. And it causes an increase in autonomic nervous system activity like tachypnea, tachycardia, pallor, or diaphoresis. And if poorly treated, it can cause psychological stress, can compromise immune system due to release of endogenous corticosteroids. So it can be visceral or somatic pain. Visceral, by the name, means any pain that comes from the internal organs. It's difficult to pinpoint as it's diffused in the nature. And there is a general aching or squeezing pain. Somatic pain further is divided into superficial and deep pain. As the name suggests, superficial is the pain of the cutaneous pain, and it arises from the superficial structures like skin, subcutaneous tissue, and it is sharp and burning pain in nature. While deep somatic pain, it arises from the deep body structures such as periosteum, muscles, tendons, joints, and blood vessels. Strong pressure, ischemia, tissue damage acts as a stimuli, and in this radiation of the pain may also occur. And the chronic pain, any pain that lasts longer than 3 to 6 months, and it persists a month or beyond, then you usually recovery period, according to American Chronic Pain Association. And it represents low level of underlying pathology that does not explain the presence of an extent of pain, for example, in fibromyalgia syndrome. Currently available treatments are rarely capable of eliminating the noxious sensations and thereby curing the chronic pain. Environmental, emotional, and cognitive factors interact with the already sensitized nervous system. So this chronic pain can be nociceptive, neuropathic, or functional in origin. So chronic pain can be presented with ongoing tissue damage or without ongoing tissue damage, but there is central sensitization is a constant feature in this. Central sensitization basically refers to a condition where central nervous system, that is our brain and spinal cord, they become more sensitive to pain signals. And this heightened sensitivity means that even normal sensation can be perceived as painful stimuli. Neuropathic pain is a result of an injury or malfunction of nervous system, and it is characterized by throbbing, burning, shooting, stinging, or sensitivity of the skin, that is allodynia. The mechanism of neuropathic pain includes when there is a nerve damage or persistent stimulation. There is further rewiring of the pain circuits, both anatomically as well as biochemically, and it leads to spontaneous nerve stimulation. And further, it leads to autonomic neuronal stimulation, which causes neuropathic pain. And based on transmission, pain can be fast pain and slow pain. Fast pain is felt in about 0.1 second after pain stimulus is applied, and slow pain usually begins after 1 second. Fast pain is described as sharp pain, pricking pain, or acute and electric pain, while slow pain is described as slow, burning, aching, throbbing, nauseous pain, and chronic pain. And fast pain is usually not felt in most of the deeper tissues of the body, while slow pain is associated with the deeper tissue disruptions. Now we come to our most interesting part of this slide, that is pain pathway. So first of all, I'll be discussing about sequence of events. there are basically 4 sequence of events in the pain pathway. There is transduction, transmission, modulation, and perception. So what happens in transduction? There is a generation of action potential in the nociceptors by stimuli. That is, whenever there is injury to the end organ, the mechanical part of the injury is converted into the electrical form. This is called as transduction. And then there is transmission of this signal to the cerebral cortex by 3 neurons. There are 3 order of neurons. So this is called as transmission. And modulation means modulation we can see over here. The periequilateral gray matter fibers, they are carrying this modulation fiber pathway. So this is basically responsible for decreasing the pain. So the process by which neural activity may be altered along the pain transmission pathway is called as modulation. We'll be discussing about this modulation part in the coming slides also. So it's very important. And finally, perception. Perception means there's subjective sensation of pain from activation of somatosensory and limbic cortexes in the brain. So whatever we feel is part of the perception. So basically, transduction, then transmission, and then perception. And the modulation is the pathway that controls the pain, that basically reduces the pain. So we'll be discussing about the nociceptors first. And so these are specialized endings of the primary afferent sensory neurons that respond to noxious stimuli. And they are free nerve endings. It is a site of energy transduction. So basically, when the transduction occurs, basically when the injury occurs, this injury is converted to electrical energy from these nociceptors. It may be low or high threshold, ability to encode the intensity of nociceptors in terms of increasing firing frequency of action potentials. And following repeated stimulation, they display sensitization. So basically, there is a primary hyperalgesia when we provide repeated stimulations on these nociceptors. So 2 types of nociceptors. First are mechanonociceptors. By name means like they respond to the mechanical stimuli. And basically, they're present on the terminals of A delta fibers, which carry fast pain. While polymodal nociceptors, they can be activated by mechanical, chemical, and thermal stimuli, and they're present on the terminals of C fibers, which carry slow pain. And silent nociceptors they indicate the presence of inflammation, and they have a really important role in sensitization. So these are the nociceptors, and they have receptors over here. Receptors for all the neurotransmitters like glutamate, mu and delta opioids, substance P, somatostatin, and vanillin receptors like TRPV1 and TRPV2. Nerve fibers are involved in the nerve fibers that are involved in pain transmission. Basically, 2 nerve fibers are involved. These are A delta fibers and C fibers. So A delta fibers are fast conducting. They move with a velocity of 4 to 30 meters per second. They are thin myelinated and respond to heat, pressure, and chemicals. And they are responsible for sharp sensation of pain. While C fibers, they are slow conducting fibers, and they move with a speed of 2.5 meters per second. They are unmyelinated, and they are more common as compared to delta fibers, and they respond to all type of noxious stimuli. They transmit prolonged, dull, aching, burning pain, and they require high intensity stimuli to trigger a response. So these are different chemical mediators. Excitatory like substance P, calcitonin, gene-related peptides, glutamate, aspartate, while inhibitory like acetylcholine, enkephalins, beta endorphins, norepinephrine, GABA, etc. So now we'll be coming to our pathway, the pain pathway. So what happens whenever there is injury or trauma to the end organ, this transmission is carried out by 2 fibers that is C fibers and A delta fibers with cerebral cortex. So how they basically move? So there are basically 3 main types of fibers that relay sensory inputs from the periphery. The cell bodies of all these fibers, they lie on dorsal root ganglia, and where they synapse with the secondary afferent, that is second order neurons. And in the rex lamina, so lamina will be covering the coming slides. So basically, these fibers they relay in the rex lamina. That is the second lamina of this dorsal horn of the dorsal gray horn of the spinal cord. So the dorsal horn in the area of synaptic transmission between primary and secondary afferent neurons in the rex lamina. Lamina 2 and lamina 3 are called as substantia gelatinosa. So I'll show you the laminas. So these are the laminas in the dorsal horn of the gray matter of the spinal cord. So basically the second and third, they carry the nociception. So the dorsal horn is the area of synaptic transmission between primary and secondary afferent neurons in the rex lamina. And so after that, the first order neurons are done. Second order neurons, they take over from the rex lamina 2, and they decussate and they basically move on the contralateral side of the spinal cord. And from there, they move along the second order. These are the second order neurons. They move along towards the cerebral cortex, towards the thalamus through lateral spinothalamic tracts. So basically, lateral spinothalamic tracts, they carry pain and temperature sensations, while there are anterior spinothalamic tracts also which carry light touch. So basically, I've told you about A delta and C fibers. So A delta fibers are fast, while C fibers are slow fibers. So fast fibers, they pass through the brainstem with no intermediary synapse. So when these fast A delta fibers are moving towards the thalamus, there is no intermediary synapses. And before terminating in the ventral posterior nucleus of the thalamus, right? So they terminate in the ventral posterior nucleus of the thalamus. From here, there is tertiary. From here, the tertiary neurons project to the somatosensory cortex, and they are responsible for conscious perception and memory of the pain, as well as its discrimination, that is location, intensity, or quality. While slow fibers that are carried out by C fibers, they synapse in the brain stems. When they are moving upwards, they keep on synapsing on 2-3 parts. First, they will synapse to the brain stem's reticular formation, and then directly to the intralaminar nuclei of the thalamus. So before projecting to hypothalamus and limbic system and autonomic centers. So after they relay the centers in the thalamus, then the third order neurons or tertiary neurons, they take over, and these fibers project to the cingulate gyrus in the cortex, and they are associated with effective arousal, as they carry fibers from the reticular formation, so they are responsible for arousal component of the pain. So from these slow fibers, they also are connected to the spino-reticular tracts. So terminating in the reticular formation. Over here we can see. And spinomesencephalic tract, that is the midbrain. These terminate in the midbrain, and over here we have the nucleus called as periaqueductal gray matter nucleus. So this nucleus is a very important role in the modulation of the pain that we'll be discussing. So this was the pain pathway, that is spinothalamic pain pathway. So now we'll be covering our modulation part. So there are periaqueductal gray matter. So what happens between third and fourth ventricle, we have cerebral aqueduct. So around the cerebral aqueduct, we have nuclei called as periaqueductal gray matter. So they are present in the midbrain, and this is the main descending pathway. So it receives projection from the thalamus, hypothalamus. After the pain pathway is done, they receive the projection from thalamus, hypothalamus, amygdala, and cortex, and they deliver their projections to the nucleus raphe magnus. Over here we can see nucleus raphe, and towards nucleus reticulus gigantocellularis also. And from there, they will descend towards the rex lamina 2, where the first and second order neurons are connected. So over here, they will transmit, and they will release the transmitters, and the transmitter that they include are endorphins, the natural morphine that we call, and enkephalins, and they also release serotonins. So periaqueductal gray matter fibers, they also release serotonins. So through this pathway, they basically reduce the pain. They modulate the pain. So we can say that they are releasing serotonin and norepinephrine also. So the people who are consuming antidepressants like which increase serotonin and norepinephrine, these antidepressants are also responsible for reducing the pain along with the opioid medications. So first order neurons, these are these are pseudo unipolar neurons. So what does pseudo unipolar neuron means? They have a unique structure where the neurons have a single axons that splits into two branches basically. So these neurons do not have separate dendrites and axons like typical multipolar. So these neurons do not have separate dendrites and axons like typical multipolar neurons. Instead, they have a single process that bifurcates into two parts. So they give two branches basically. So peripheral branch and central branch. So peripheral branch is a sensory branch. It receives the signals, while central branch it sends the signal to the neurons that are moving forward. And rest we have explained first order neurons. So this is the differential distribution of large and small efferent fibers into lamina of the dorsal horn. So over here we can see first is marginal layer, then there's substantia gelatinosa, and then we have nucleus proprius. And now we come to the laminas. We have laminas from 1 to 10, but our major laminas for the concern are 1st to 6th. First and second lamina, they carry somatic nociception, thermoreception, and third and fourth, they carry mechanoreception, which are present in the nucleus proprius. And fifth lamina, this is the fifth lamina. This is responsible for visceral and somatic nociception and mechanoreception, and they are called as nucleus proprius WDR neurons, that is wide dynamic range neurons. So basically, this fifth neuron, this is very important. Fifth lamina, this is very important. This contains part called as nucleus proprius wide dynamic range neurons. So these are the different Rex laminas from 1st to 10. So basically, C fibers, they are mainly moving in the lamina 1st and 2nd. A delta fiber, they move along 1st and 5th. And visceral mainly go to lamina 5th and also in 1st. And they are responsible for convergence. And they also are responsible for the referred pain. And first lamina, there is a somatic nociceptive stimuli. Second, we have interneurons. So on the modulation pathway, first and second neurons are connected through interneurons. So these are present in the second lamina. Third and fourth, they have non-nociceptive sensory inputs, A beta and pain A delta fibers. Lamina fifth receives both somatic and visceral and both noxious as well as non-noxious stimuli. Second order neurons we have discussed. This is the pathway we have already discussed. And spinothalamic tract we have discussed. So we have discussed that the spinothalamic tract fibers, the slow train fibers, they move along whenever they are moving upwards. They give the fibers to RAS, that is through spino-reticular fibers, which is responsible for arousal, activation of endogenous energetic system, autonomic centers in the brainstem, and through midbrain, through spino-mesencephalic fibers, they have periaqueductal gray matter fibers, which are responsible for pain modulation. And in the limbic system, that is spino-limbic tract, they are responsible for emotional aspect of the pain. And these third order neurons. Now we'll come to our the important part of this slide, that is gate control mechanism. So basically, pain is modulated through two parts. First is the descending pathway that we have already explained, already covered. And second is the mechanism called as gate control mechanism. It was proposed by Melzack and Wall in 1965. So what happens in this gate mechanism? it postulates that the pain transmission from primary to secondary efferents is gated by interneurons, right? So in the substantia gelatinosa, we have interneurons between first and second order neurons. So inhibition can be presynaptic on primary, while it can be postsynaptic on the second order neurons or secondary efferent neurons. So the gate control mechanism basically opening of the gate basically means the gate is open presynaptically by C fibers via substance P. Opening of the gate is basically opened by C fibers and postsynaptically by enkephalins, action of the enkephalins interneurons at the level of substantia gelatinosa. Thus, they allow transmission of pain signals. While closure means it is closed by descending inhibitory pathway, inhibitory fibers, and peripheral A beta fibers indirectly by the action of A delta fibers on descending pathway. So these A delta fibers, they give their signal to the descending pathway. They can also indirectly control the closure of this pathway. And A beta fibers, they inhibit C fibers input presynaptically via stimulation of GABA receptors. And this is basically the gate control theory of pain. You might have noticed whenever there's a injury to any part or head, we usually start rubbing to that part. So basically, what we are doing, we are stimulating the other touch fibers by closing the gates of the that is through A beta fibers. So A beta fibers will stimulate the inhibitory neurons, and they will further inhibit the projection neurons that are that are carrying the pain fibers to the brain. And basically, the gate control theory of pain is a well-established concept, and it explains how pain is transmitted and processed by a nervous system. And in simple view, pain receptors in the skin, they detect harmful and damaging stimuli, and they send signal to the spinal cord. And spinal cord processes these signals and determines the intensity and quality. And then A beta fibers, they transmit non-painful sensations like pressure and vibration touch, while A delta and C fibers, they transmit painful sensations. So when A beta fibers are activated, they close the gate, reducing the transmission of pain. While A delta and C fibers, when they are activated, they will open the gate, allowing pain signals to reach the brain. So this is the gate theory of the pain. Thank you.
Thank you, Dr. C.K. Now we shall move to the different part of our presentation, that is role of USG in day-to-day anesthetic practice. Field of USG is very immense. You can apply USG to probably every part of our clinical practice. Maybe it is cancer pain, chronic pain, trauma, labor analgesia, and the spectrum is wide. And it is really wonderful use of USG. It has made an immense effect on our clinical practice. But today, now this part of our presentation, it will restrict to the use of USG in the clinical practice of anesthesia in OTs, almost in our OT setup. So Dr. Vikas Gupta will be enlightening us by a certain role of some uses of USG in anesthetic practice and their advantages. Means what the focus will be. Before start of USG, these blocks were never been feasible. It is only through USG that we are able to use these blocks, and it has made an immense effect on our clinical practice in anesthesia. So now we shall be starting. Dr. Vikas Gupta will be enlightening you about the use of USG in these blocks. Okay, Dr. Vikas, please.
Am I audible? Am I audible now? Good evening, all. First, Happy Doctors Day to all. Regards to the dignitaries sitting here, and now we will start our people. Now we start our today's lecture of role of ultrasound in anesthetic practices. See, anesthesiologist requires quick and accurate diagnostic tools for effective management of emergencies. So, for this, ultrasound is a safe, easily accessible point of care imaging modality that is being increasingly adopted in modern anesthesiology practice. So, what are the current and potential applications of the ultrasound? It will be used for regional anesthesia, it will be used for neuroaxial and chronic pain procedures, it will be used for vascular access, it will be used for airway assessment, it will be used for lung ultrasound, gastric ultrasound, EFAST, and focused transthoracic echo. So in today's class, we will discuss about blocks, nerve blocks, which we are using in day-to-day practice or in OT practice. So ultrasound has become a commonly used modality in the performance of chronic pain interventions and has begun to substitute the CT scan and fluoroscopy in many chronic pain procedures. It allowed direct visualization of tissue structures while allowing real-time guidance of needle placement and medication administration. So what we can do with ultrasound, we can do nerve root blocks, stellate ganglion block, transforaminal injection for radicular pain, and intra-articular joint injections. So in today's class, we will focus on nerve blocks. So there are three techniques by which we can give nerve blocks. First is landmark guided blocks, second is penis guided blocks, and third is USG guided blocks. See, in landmark guided blocks, we are almost blind. That in that diagram, you can see that the target will hit or not hit, not sure. In penis guided, we sometimes we can hit properly and sometimes we can't. But USG, we can hit the precise. We can hit the precise and we can give precise blocks by the use of USG. So in today's class, we will discuss more about facial plane blocks. So why we need facial plane blocks in our toolkit? Because renal anesthesia is a part of multiple analgesia. We need to increase anesthetic delivery so more patient can benefit. So, see, some facial plane blocks are very simple to teach and perform, and some very difficult. And if we can't perform classic blocks, there are alternatives also, so that we can perform that blocks. See, this is a vague picture of facial plane blocks we can give in our OT by the use of USG. So, where may facial plane blocks have a role? See, if we can't give epidural, spinal, or paravertebral blocks in like coagulation, sepsis, and certain cardiac toxicity, cardiac anomaly, there is hypotension, so it will be used as a rescue technique. If we can't perform epidural, spinal, or paravertebral, so it will be useful in that case. See, these are alternatives of paravertebral block and epidural block. In spite of paravertebral, we can give PAC, serratus, MTP, and atrospiny. If in spite of epidural, we can give rectus sheath, quadratus lumborum, TAP, atrospiny, or serratus anterior block. So, what is fascia? We are talking about facial plane, but what is fascia? So, what is fascia means? This soft collagen containing the loose and dense fibrous connective tissue is permeate whole body. There are two types of fascia: the superficial fascia and deep fascia. So, in our nerve blocks, we are more discussing about deep fascia. So, deep fascia will be multiple layers, fibrous, is extended throughout the body. It is the main target for facial plane blocks, and it forms sheaths for nerves, vessels, and organs. So, what is the mechanism of action of facial plane blocks? So, if I can say frankly, this mechanism of action is not known. But we can say that how we are giving the injections, that LA action depends on that thing. That if we inject the drug in the plane in which the nerve is situated, or we are giving in adjacent planes, or we are giving in distant planes, this it will block this by the systemic absorption. So nerves in the injected planes means hydrodirection by hydraulic pressures like rectus sheet, tap, pack, like that. And nerve in the adjacent plane means we are giving some near to the plane. So by diffusion or seepage or concentrated gradient, that drug will go to that plane and it block the nerve, like pack, rectus spiny block. And now at a distant site, so by the systemic absorption, it will act. So what we are doing now routinely, like we are giving brachial plexus block for upper limb surgeries. Supraclavicular block, interscalene block, infraclavicular block, or axillary block. These blocks are, we all are doing, giving this block for upper limb surgeries. But the main, we are not, I will not discuss these blocks because these are day-to-day practice. We are using these blocks, you know. But main problem in that, if the patient having the respiratory depression or some lung pathology, so if we give these blocks, that 10 to 15% patients may have phrenic nerve involvement, and it will cause the diaphragm paralysis or hemithorax. So nowadays the new concept has come, the phrenic sparing blocks. We are giving these blocks for upper limb surgeries, but the phrenic nerve will be spared in that. So what are the blocks for phrenic sparing blocks? The costoclavicular block, suprascapular block, axillary nerve block, or clavipectoral fascia block. So first we will discuss the costoclavicular block. Costoclavicular block basically is a type of infraclavicular block. In that, we will block the brachial plexus at the level of cords. We can do all the surgeries below the shoulder. In that, you can see in this picture that we have to identify the two or three structures in that. First, patient position. Patient lies in supine position. We will place our transducer linear. We are using linear probe in that, in the medial infraclavicular fossa, parallel to the clavicle, and we have to identify the axillary nerve. This axillary nerve we have to identify. This axillary nerve and this axillary artery we have to identify. This axillary artery. Okay. Then that plexus will be seen lateral to that artery. So this, you see this hypoechoic oval structures. In that, the three cords are there, the posterior, lateral, and medial cords. See, these three cords are there. These three cords are there. So we have to identify the three cords. So needle in plane, we will using in plane approach, lateral to medial, and we have to identify these three muscles in that: the pectoralis major, the subclavius above, and serratus anterior below. So we will go in plane, lateral to medial, and the needle will go like this, and we will enter in this oval plane, and we will inject 0.5% opivacaine 20 ml drug. It will equally effective, and it will block all three cords at the same level. So it is a very good block, and in that phrenic nerve also spared. So we can do all type of surgeries with costoclavicular block. Like if we want to do humerus nail, so previously we usually what we are doing, that interscalene plus superficial cervical plexus block. But nowadays you can interscalene, the phrenic nerve will be involved. So nowadays costoclavicular block plus axillary nerve block or suprascapular nerve block, we are using these things. So it will be very useful for that, for all shoulder surgeries and all lower upper limb surgeries. See, now suprascapular nerve block. The suprascapular nerve block, the transducer will be placed in the coronal plane or a suprascapular fossa. See, we have to we have to see the spine of the scapula, and we have to put our probe over that spine of scapula, directly over the spine of scapula. And what we are seeing, we have to search for that. We have to search the notch, suprascapular notch on the floor of this is suprascapular notch. See, this is a floor of scapular spine, and this is a suprascapular notch. In the suprascapular notch, there is a ligament is there. See, this is a ligament is there, transverse suprascapular ligament. This is so the suprascapular nerve lies behind beneath the transverse suprascapular ligament. There is one artery also there, the suprascapular artery, that is most probably over that ligament or beneath the ligament. That anatomical variation is there. So now we have to identify the two muscles also, trapezius and supraspinatus muscles. So how we will do injections? We will do we are using linear probe. We have put the probe over the scapular spine. We are going lateral to medial in plane approach, and we are coming like this. We are coming like this. Needle will come like this. We will pierce this ligament, and we will insert in that notch, and we will deposit the drug there. That 5 to 8 ml, 5 to 10 ml ropivacaine is enough for that blocking the suprascapular nerve, and it will be useful for that use of surgery of shoulder. Shoulder means like arthroscopic shoulder surgeries and any humerus nail, or it will be useful for frozen shoulder also. That chronic interventional pain management. Now, axillary nerve block. I am not talking about axillary brachial plexus block. I am talking about axillary nerve block. It will be very useful for that shoulder surgeries, like arthroscopic surgeries. Very easy to perform that block. See, in that we have to put our transducer. We are using linear probe. We have to put our transducer over posterolateral aspect of the shoulder. This is a posterolateral aspect of the shoulder. We have to identify the head of humerus, and we have to track downwards. We have to track downwards. We are seeing the two muscles, deltoid muscles and trispinal muscles, and there is a facial plane is there. A triangular facial plane is there. See, this is the triangular facial plane is there. So triangular facial plane, if we identify the facial plane, see there in this only that axillary nerve line, and there is also posterior circumflex humeral artery also there. So how will we perform this block? We are using linear probe. Patient is sitting position. We have put our probe just below the humerus head, scan downwards, and we will identify this triangular facial plane. We are going in plane approach from caudal, cranial to caudal, like this, cranial to caudal, and our approach will be like this. We will penetrate this facial plane, and we have to put the drug there, so that nerve will be pushed towards the artery. So by this we can do all type of shoulder surgery, because axillary nerve supplies the capsule of the shoulder also, no? So in plane approach, 10 to 15 ml drug is enough for that. I mean, isko complete kar. Now fourth one is clavipectoral block. See, for clavicle surgeries, what we are using interscalene plus supracervical plexus block. Then again the phrenic nerve will be involved in that. So what we are doing nowadays, the clavipectoral block is there. What is clavipectoral fascia? Clavipectoral fascia is a fascia surrounding the clavicle. So all around the clavicle. So see, we will put our linear probe directly on the clavicle. We have to identify the clavicle. Okay, the fascia is above the clavicle, and the needle will go in plane, and we will hit the clavicle, and that identify that fascia, and we have to deposit the drug in that fascia, so that the facial plane block will be and that we can do all type of clavicle surgeries by this block, the plating, nailing, anything. So these are the 4 type of phrenic sparing blocks. Okay.
Am I audible? I just want to emphasize the blocks which Dr. Vikas is explaining to you all. For this, USG is mandate. You cannot use them without the help of USG. Practically, it is impossible to give them blindly. So the topic which we have decided, role of USG, this is actually a very big advantage of USG these days. So now we shall move to the other blocks. Dr. Vikas,
Now
please.
we will come thoracic block. Now we will come for thoracic blocks. What previously we are giving the paravertebral blocks, it will use for analgesia and anesthesia for hemithorax, thoracic surgeries, breast surgeries, VATS, breast reconstructive surgeries. So what we are doing, we have to identify the paravertebral space. So how will the paravertebral space form? It will be space between the parietal pleura, it will space between the parietal pleura and internal intercostal membrane, and the base formed by the vertebral body, and it contains the adipose tissue, intercostal nerve, dorsal ramus, intercostal vessels, and anterior sympathetic chain is there. And main thing, what is there? There is a ligament is there, a costo-transverse ligament. So what we are doing with that block, we are putting, sorry, so we are putting our probe, patient in sitting position, linear probe in paramedian sagittal orientation, that 2 centimeter from the midline, and we have to identify this transverse process. This is a transverse process. Okay, so we have to pierce that ligament, transverse ligament, and we will enter in the paravertebral gutter, and we will deposit the duct there. See, from caudal to we can use in plane approach also, we can use out of the plane approach also. In plane, from cranial to caudal. Okay, but main problem in the paravertebral block is there that sympathetic chain will be blocked in that. So if sympathetic chain will be blocked, the patient having more hypotension and bradycardia like that. So nowadays that novel block has come for in that very easy to perform, and the side effects are very less in that, and effect also much more better than paravertebral block. That is called erector-spinae block. Erector-spinae block. What is erector-spinae? Erector-spinae is a group of muscles including iliocostalis, longissimus, and spinalis muscles. It will run bilaterally from skull to pelvis and from a spinous process to transverse process and extend to that rib. So basically, it is an interfacial plane. So if you can ask me that what is the mechanism of action for that, but mechanism of action is not well defined, but we can say that interfacial spread toward the posterior rami of spinal nerves is possibly mechanism of action. So patient, we will put the patient in sitting position, linear probe in the paramedian sagittal orientation, 2 centimeters from the midline, and try to visualize this transverse process. See this transverse process. Okay, this transverse process. See, now you can see the 3 muscles are there. 3 muscles: trapezius, rhomboides major, and erector-spinae. But above T5, you can see this all 3 muscles. But below, if we give block below T5, the rhomboides major will not be seen. So trapezius and erector-spinae. So needle in plane from cranial to caudal until the needle contact with this transverse process. See, we have to this needle orientation. We will hit the transverse process. Then we will put the 2-3 ml drug. Hydrosection will be there. Then we will they confirm proper injection of the visualization LA in that erector-spinae muscles and superficial the transverse process, and below the erector-spinae muscles. And we will give our drug, 15 to 20 ml drug is enough for 4 segments above and 4 segments below. And we can give this block bilaterally also. Now we will discuss about pack block. This pack block basically used for breast surgeries. The 2 type of pack block, pack 1, pack 2. In pack 1, we are giving our injections, the drug between the pectoralis major and pectoralis minor muscle. This is facial plane. We are giving that drug. And if pack 2, we are giving our drug between pectoralis minor and serratus anterior muscle.
You just finish with the thoracic and we start the next.
Okay. This is pack block. We use linear probe from cranial to caudal. Middle orientation is there. In plane approach, we will use. If we want to give pack 2 block, we have to use. We have to search for 4th rib, and if we want to give pack 1 block, we have to search for 3rd rib. Okay. And if I can say, if I have to give both blocks simultaneously, pack 2 and pack 1, so I will give pack 2 block first, so that that anatomical disturbance will not be there. So that is pack block. Now the thoracic part of that blocks have completed. Now, Kavita ma'am, I am hand over the mic to Kavita ma'am.
Hello, can you hear me? I think we should start with some MCQs in between what Dr. C.K. Sharma has just presented and what Dr. Vikas has just presented. Half of his presentation is there. Let us start with some MCQs. Am I audible?
Yes, ma'am.
Okay. So the MCQs relating to Dr. Vikas presentation and Dr. C.K. Sharma, pain pathways. Okay. Is everybody ready?
Yes,
Okay,
ma'am.
first MCQ is, which is not a phrenic sparing block? A is costoclavicular block, B is axillary nerve block, C interscalene block, D suprascapular block. Which of them is not a phrenic nerve sparing block?
Ma'am, the choice is C. C is pouring in like anything.
Choice
C. Everyone has put C.
C. Okay. Fine. So next,
It's the correct answer.
C is the correct answer. So
Okay.
do we have any prizes for correct answer?
Ma'am, you will only have to give the prizes.
Okay then.
Or we'll ask
We'll
Bajwa
give
sir
a
to
big pat on
sponsor.
their shoulders.
Yes, ma'am.
Next is, this has not been presented till now, but I think these people must be knowing what is PENG block, P-E-N-G block. Posterior encapsular nerve block, posterior lateral entry nerve block, pericapsular nerve group, none of the above.
Again, it's maximum C and one person has told A also.
I think C is most applicable answer,
Yes, ma'am.
right?
Yes, ma'am.
Okay. Next, which very easy. Which nerve will not block in fascia iliaca block? Not block. Okay. Femoral nerve, obturator nerve, lateral cutaneous nerve of thigh, none of the above. Answer is
There is a mixture of C and A, madam.
C and A are blocked. We are asking not blocked.
Oh, there's B also.
Correct answer is B, obturator nerve. That area is not for obturator nerve, right?
Mm.
So Akansha has given. Next. Which is high frequency probe? Linear probe, curvilinear probe, both or none of the above?
A.
Linear probe.
Yes.
So how many people have attempted this question?
Around 8 to 10 people, ma'am.
Oh, this seems they are not using USG.
Some have given C, some have also given A. Both. Mhm.
Anyway, but I think having a USG machine in anesthesia department in OT is a mandate now. Next. Shamrock sign is seen in tab block, quadratus lumborum block, femoral nerve block, rectus sheath block. This is difficult, I know.
Yeah, we are giving answers. तो सही दे रहे सारे.
Well, so answer is
B.
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 Answer is
B.
B.
B. B. They have given for B.
fine. Thumbs up sign. Nice. Next. Okay, this is very painful, this question. Which endogenous opioid peptide predominantly interacts with kappa receptors to mediate analgesic effects? नहीं. Which
Again, it's
endogenous
maximum A.
opioid?
Maximum A choice has been given.
A.
No.
No. With kappa receptors to mediate analgesic effects. तुमने क्या चॉइस रखा? Dynorphins. I think endorphins can also do it. Okay.
What
So
is
the
the
correct
right
answer
answer?
is dynorphins.
Dynorphins. Okay. What is the difference between endorphins and dynorphins? I think that you can just.
That is the. Can we switch to the previous slide? जिसमें हम dynorphins और endorphins का difference explain करेंगे.
Yeah. Yes, you are audible, ma'am. Yeah.
Dr. CK, please explain.
So basically, am I audible?
Yes.
So their dynorphins, they basically bind to kappa opioid receptors, and their function is involved in pain modulation, particularly in promoting analgesia through kappa receptors. And while endorphins, they primarily bind to mu receptors, and they affect mu receptors. Activation by endorphins typically lead to strong analgesia.
Okay.
Yes.
Yes.
Next, please.
Ma'am, remaining MCQs we'll have after the next presentation.
Just let me see one more is there. This
Oh.
sounds of interest. Please, एक बार next one. एक बार. नहीं मेरा चल रहा है. Which neurotransmitter is known for dual role in pain modulation, exhibiting both pro-nociceptive and anti-nociceptive effect depending upon the receptor subtype? Dopamine, serotonin, norepinephrine, or GABA? Answer is?
Question नहीं आया इस पर.
Yes, the question is seen clearly. There's no
Clear
problem.
now? Okay.
Yes,
So answer
ma'am,
is?
this is the question. Only one, some people have attempted. I think they have said D.
नहीं.
D.
D and B. Yeah.
Okay. B, serotonin is a dual role in pain modulation.
So the answer is serotonin, ma'am.
Yes.
Okay.
Chalo, we'll do remaining MCQs later on. We'll start with the presentation again.
Yes.
So I just wanted to make the people awake from this painful presentation. So let's switch again.
So now we will come to that abdominal blocks. First, I will discuss about the quadratus lumborum block. Then we will discuss about tab block and rectus sheath block. The three types of block we are giving it for abdominal surgeries. So first, quadratus lumborum block. It is a block for posterior abdominal wall. That is, it is also an interfacial plane block because we are giving local anesthetic in the thoracolumbar fascia, which is a posterior extension of the abdominal wall muscles, and it will encompass the back muscles like psoas major, quadratus lumborum, erector spinae, that will encompass this. So the thoracolumbar fascia basically is extend posteriorly and connect with the lumbar paravertebral regions. There are 4 types of quadratus lumborum block we can use by that the approach by that quadratus lumborum block 1, 2, and 3 and 4. And 1 we are using lateral approach, 2 posterior, 3 anterior or transmuscular, and 4th is intramuscular. So the best is transmuscular approach, very easy and it will very effective. And in that also, in this only we can see the shamrock sign. What is shamrock sign? The shamrock sign, see this, you can see this L4, this we can see the process, this L4. Can see all can identify this transverse process of L4. This is like stem, and the 3 petals are there. The 3 muscles like 3 petals are quadratus lumborum, the psoas major, and erector spinae. The 3 petals are there. So this is shamrock. We can also call it like a thumbs up sign also. So in that transmuscular approach, we have to put the patient in that lateral decubitus position. That USG linear probe we can use. Linear probe placed over above the iliac crest at the mid-axillary line, and we have to identify this shamrock, the shamrock sign. Okay, then we will put our needle in plane. From we have to go like this, and see our needle will come like this, and we have to pierce this quadratus lumborum muscles, and we will deposit our local anesthetic between this quadratus lumborum and psoas major. So this is the facial plane, and that we have to deposit our drug. So our needle will come like this. We have to pierce the quadratus lumborum, and we see this psoas major and quadratus lumborum. Between that is a facial plane, and we will deposit our drug there. See, so this is the quadratus lumborum block. Now the tab block is a superficial block. We can also use this for surgeries for anterior and abdominal wall surgeries, and it will provide analgesia for abdominal wall in any laparoscopic surgeries or any abdominal surgeries. We can use this tab block. So in tab block, usually we are using linear probe. We will put our probe horizontally over the abdomen, the anterolateral, and we have to identify these three abdominal muscles: this external oblique, internal oblique, and transverse abdominal muscle. So there is a facial plane in between that internal oblique and transverse abdominal muscle. So this is a facial plane is there. So our target point is this facial plane. So the needle from medial to lateral, we will inside our needle in plane, and we will reach this facial plane, and we will deposit our drug there. So it will almost 15-20 ml drug is enough for that. We can use this tab block bilaterally also. So this is a rectus sheath block. Rectus sheath block. See, we will deposit our rectus, our local anesthetic in between rectus abdominis muscle and posterior rectus sheath. So this is our plane. So we will deposit our drug there. So what we are using, we are using USG transducer placed transverse orientation over the abdomen, just above. We can put below the umbilicus also. We can put our probe above the umbilicus also, and needle in plane, medial to lateral or lateral to medial, both we can easily we can go medial to lateral, and we will deposit our drug between the rectus abdominal muscles and posterior rectus sheath. So this is rectus sheath block. So these are the facial plane blocks. We can for that we can give analgesia to the anterior abdominal wall, or we can use analgesia for the upper abdominal surgeries. So now we will come to the lower limb blocks. See, first fascia iliaca block. The fascia iliaca block is a very good block for anterior thigh and knee. Sorry, anterior thigh and knee, and it will give analgesia for anterior thigh, knee, and medial thigh. So what we will do, it's very easy to perform this block. We will put our linear probe directly on structure. This is femoral artery. We have to identify this femoral artery, and then we will move lateral to medial, and for this find we have to find this hypoechoic fascia iliaca just superficial to that artery. This is just superficial to that artery. Okay, and the iliopsoas muscles also there. Okay, so and below that there is femoral nerve is there. So we will use we will use in-plane approach from lateral to medial, and we will insert our needle in this fascial plane, and this fascial plane, and we will deposit that drug. It will cause the unzipping of the fascia. That unzipping of the fascia, and we will deposit that drug. So it will be very good block for analgesia purpose, for anterior thigh, knee, and medial thigh, and it will see if somebody having intertrochanteric femur fracture or head of femur fracture, so the patient can't sit in that. So first we will what we are doing in our OT. First we will do this fascia iliaca block, and then the patient can easily sit up, and we will put the patient in sitting position that very easily. So it will very good block for giving spinal also. The patient will be very comfortable in sitting position, and we can give our spinal anesthesia very easily. So this is a fascia iliaca block. See, now the second block is Pang block. Pang block is a newer block. In that, it is a fascial. It is a fascial plane block where we are depositing our drug between the psoas tendon. This is psoas tendon. This is psoas tendon, and ilium. This is ilium. Iliopubic eminence in this ilium. So our aim is that iliopubic eminence. So how will we identify this anatomy? See, we have to identify first the anterior superior iliac spine. So we will put our probe there. Then we will go downwards, and we have to identify this anterior inferior iliac spine and iliopubic eminence. See this one. See, like this. Okay, then there is Y structure is there, that is called iliopsoas tendon. There is femoral artery is there. So we should have this view, 4 block. We should have this view. This femoral artery, the iliopsoas tendon, and iliopubic eminence. So what we are blocking in that Pang block, we will block femoral articular branches of femoral obturator and accessory obturator nerve that provides sensory innervation for that anterior capsule of the hip. But see, in lean thin patient, we can use linear probe, and if patient is fat enough, so we can use curvilinear probe also. So in that approach, we are using in-plane needle approach from lateral to medial, and we will hit this iliopubic eminence, and then we have to deposit that drug there. See, in ideal block, the iliopsoas tendon should be go above, and the drug will be deposited here. So what is the main advantage of this Pang block is that it is a pure sensory block. It is not a motor block. So the the femoral nerve will be spared in that, hugely spared in that. So ideal block, we are depositing our drug just lateral to the tendon. So the femoral nerve will not involve in that. So the sensory block is a good block for all type of that femur head femur capsule or femur head surgeries. So that is called Pang block. See, now we will discuss about sciatic nerve block. Usually in sciatic nerve block, we have to put the patient. We have to see in this pang block we can't give blind. You have to use the USG in the pang block. Like this sciatic nerve block, what previously we are using, we have to put the patient in prone position or lateral position. So it's very difficult for the patient to turn that prone or lateral position. So that newer approach has come, like we can give sciatic nerve block for lateral approach, bilateral approach. See, in this diagram you can see we have to identify the anterosepalic spine, and we can give our sciatic nerve block the 4 levels. We can give at the level of ASIS, we can give the block at a greater trochanter, we can give the block at a mid thigh, and we can give block, sciatic nerve block, just 3 to 4 centimeter above the superficial, that's superior to the patella. That is called caps block for the crossover popliteal sciatic nerve block, crossover approach of popliteal sciatic nerve block. So we will discuss more about the mid thigh sciatic nerve block and cap block. So in mid thigh, in mid thigh, you have to identify this. This is your sciatic nerve is there. See, this sciatic nerve. So we have to identify the femur head, and just that lateral to the femur head, there is a sciatic nerve is there. Okay. In the cap block also, in that you have to identify the femur head. There is the popliteal vein, the popliteal artery is there, and then vasta medialis, vasta lateralis muscle is there, and they have to identify the sciatic nerve, and we will go in plane approach from medial to lateral, and we will deposit our drug near to that sciatic nerve. It's a sciatic nerve. Okay, so in that cap block, you have to see the donut sign. See, we will insert that fascia lying over the sciatic nerve. We will put our needle beneath inside that fascia, and we have to put our local anesthetic there. So there will be donut, means that nerve will be surrounded by all over from the local anesthetic. So this block, by this block you can do surgery also. We can give anesthesia also with this block. If we give from femorosciatic block, we can do all type of surgeries below for knee and below the knee surgeries. So this is the very good block, and in that also we can put main advantage of that, the patient will be in the supine position, and we can use our block approach from the lateral side. So it will be very good block for lower limb surgeries. See, and it will lateral approach we can't give by blindly, very difficult to give blindly. So USG mandatory for this block. Now the 4th block is adductor canal block. And adductor canal block is very useful for the medial foot and ankle surgeries or knee surgeries for analgesia. See, we have to identify the sartorius muscle in the sartorius muscle. Vastus medialis, sartorius. Okay. So what we are doing, we will patient in supine position, his thigh is abducted and action rotated to assess the medial side of the thigh, Okay. See, then we will put our probe over the medial thigh, and we have to identify the superficial femoral artery. This is superficial femoral artery. Okay. So just lateral to the superficial femoral artery, there is a facial plane. There's a fascia of vastus medialis, and that fascia of vastus medialis, there is this that nerve lying there. What is the nerve? This is the saphenous nerve. So we have to block this saphenous nerve. So we will go needle in plane, lateral to medial, and we have to pierce the sartorius, and we will insert this plane, and we have to deposit the drug there. The 5 to 10 ml drug is enough for this for block of saphenous nerve. So mainly saphenous nerve. What is saphenous nerve? Is a terminal sensory branch of the femoral nerve. So we have to find that just deposit that we have to identify the artery and just deposit the drug just anterior to the artery, and we will block the saphenous nerve. Okay. Now the newer block has come, like called as SPADI block. What is SPADI? SPADI block is that single penetration dual injection block. In that we can block both nerve as a single penetration, like sciatic nerve and saphenous nerve. So what we have, it is called anterior approach of sciatic nerve block and it's a saphenous nerve block. So we will put patient in the supine position, and we will put our low frequency cavernous probe just 10 centimeters below the lingual ligament, and we will and identify that this one yellow structure and this yellow structure, the sciatic nerve, and this is saphenous nerve. Okay, so we will go in plane from lateral to medial, and first we will hit the sciatic nerve, and we will deposit our drug there, and then we will withdraw the needle, and lateral to the femoral, superficial femoral artery, we will deposit our drug there. That is, we will block the saphenous nerve. So what is this? This is femoral head, and we will identify the femoral head and the sciatic nerve, saphenous nerve, and superficial femoral artery. So that is called SPADI block. That is now last block. We will discuss this popliteal block. This popliteal block is very useful for the below knee surgeries. We can do our surgery also, and we can do surgery also in that popliteal block. In popliteal block, that 2 or 3 approaches are there. We can put patient in prone position, we can put patient in lateral position, and what I am using routinely, that I will put the patient in supine position. I will put below that ankle, and I will put the probe directly in the popliteal fossa. And what we will see that we have to identify the popliteal artery and popliteal vein, and we have to identify the 2 nerves are there, the foramen nerve and tibial nerve. So we will go in plane from lateral to medial, and we will block both of these drugs, both of these nerves, so the foramen and tibial nerve. So these are the commonly blocks we are doing in our OT. So thank you. Hope you understand these blocks.
I would take a few minutes just to question. Be good. I think we had a good amount of exposure regarding the blocks under USG. Currently, I am working in emergency medicine, so I realized role of USG in emergency medicine is also immense, and that to be used by anesthetist. Currently, most of the emergency physician are it is an extension of anesthesiology only. So Dr. J.B. Nagal will tell you the role of USG in emergency medicine, which is very dramatic, and very interesting. So Dr. J.B., would you please like to explain few words about role of USG in emergency bedside investigations? इनका होने दो पूरा. Unless he explain, nobody can answer the MCQ. दो बच्चे हैं अपने MCQ वो इनसे related. Dr. J.B. start please. We are very short of time. Dr. J.B. please start.
मैं म्यूट कर रहा हूँ.
वीडियो कैसे आएगा?
क्या होगा? मेरे स्क्रीन आई तो देख सकते. Starting very soon. I think you can see the slides. Presentation थोड़ा सही करो भाई.
Yes.
These are on arrival blocks, scopus, airway assessment, lung scan, E-fast. E-fast is very useful for trauma protocol. This EFAST is a wonderful investigation of USG bedside. I have done in many patients these days, and the results are immense. Patient comes with hemorrhage, intra-abdominal hemorrhage. तुम्हारा presentation
Yeah, but
Am I audible? Good evening, all my respected seniors and dear PG students. We are anesthetic and we are also perioperative physician and also emergency physician. I think every PG students every time received a call in night or in evening that there is a patient received that is unstable, kindly do something, kindly help. On that time, whenever we reach in casualty, there is a very short time. In golden hour, in golden period, we have to stabilize, we have to diagnose, and we have to give some emergency treatment, and also we have to diagnose what is the etiology. So in that part, USG becomes a biggest tool and very handy tool. And on that time, pain is fifth vital sign, as previously discussed. We can use on arrival blocks because patient is in so much pain that every time he tells pain is so much severe, please do something, please do something. Then we have to give some blocks that was already discussed, brachial plexus block and fascial blocks. Sometimes femur fracture is so much painful that before shifting the patient to X-ray room, patient wants some analgesic. At that time, the second thing is focus. Nowadays,
Dr. Vikas? Dr. Vikas, your voice is not audible.
Yes, ma'am.
Yes, now you're audible. Yes, now you're audible.
Okay. And after on-arrival blocks, the focus is so much important in casualty for the diagnosis, rapid diagnosis, and we do not need to shift the patient to radiology department because shifting is, on that time, shifting is killer. We have to stabilize patient, and side by side, we have to diagnose something, the etiology. On that time, focus is so much important. In the focus, sometimes we receive tracheobronchial injury, and that is that is not so much visible. On that time, airway assessment with the USG is so much important. I can share the slide. We can see there's a string of pearls. We can see if there is any damage to tracheobronchial tree, we can see distortion in string of pearls. There is a left upper corner. And also in the intubation, there is a bullet sign or snowstorm sign, that is confirmation of intubation. On sometimes in trauma patient, intubation becomes so much difficult. On that time, USG will so much important. And the right lower side image is showing esophageal intubation, which is a double tract sign. And the next is a lung scan. Lung scan is very much important for us in OT and also in casualty, because sometimes X-ray is not providing full information. On that time, lung scan, just putting the probe on lung area, we can see the image in left side is showing on the M mode that is barcode sign, that is seen in pneumothorax. And in that image also, left side is sea beach sign, that is lung point, definitive diagnosis of pneumothorax. And this as right side image is showing the B lines, that is definitive diagnosis of any pulmonary edema or pneumonia. or LVF patient is also showing the pulmonary edema and the B lines. So blue protocol is so much important, more important than the X-ray and CT, because it is very handy through the USG. CT scan, we have to patient move in the radiology department, so much shifting time, and the patient on that time is unstable on inotropic support. We can use just USG probe and we can diagnose so much important and early diagnosis. The next is emergency cardiac assessment. Sometimes we suspect that there may be ejection fraction will be low, or there may be RWMA, regional motion wall abnormality. On that time, we can put the probe on just a parasternal view. This is looking so much difficult, but it's not difficult. If we can practice, just we can see, just we have to locate just a parasternal view. We have to locate the mitral wall E-point separation. This is mitral in M mode, the mitral wall flap touching the interventricular septum, and we can diagnose what is the problem and what is the rough estimate of ejection fraction. That is also important in OT also. And this is a left side image is showing that LA clot, sometime patient received in AF, sometime patient received in AF, and we have to cardioverse that. But before cardioversion, it is mandatory that we have to rule out that is chronic and LA clot, whether it is present or not. So LA clot, looking for LA clot is mandatory in that situation. And also right side image, we can diagnose the regional motion wall abnormality. Just the short axis view and LV, we can see whether it is contracting or not. To the complete part, this is salpetric, that is septal, anterior, lateral, posterior, and inferior. We can somewhat estimate of ejection fraction or RWMA. That is so much important. Within 2 and 3 minutes, we can diagnose what is the status of the cardiac status of the patient. And every time patient received in OT or in casualty, we have to assess what fluid is should be given and what volume of fluid should be given. Sometimes there is cardiac patient or volume status we not known. Then IVC assessment is so much important in critical care, also in casualty, in OT. Then left side image is showing the IVC. IVC, there is collapsibility, whether it is less than 50% or more than 50%. It is very handy tool with the USG. And the right side, we all do daily practice on day-to-day practice. This is IJV cannulation. Through USG, it is a fraction of time we can put IJV so much easily without picking any vessels, other vessels. And the this is latest optic nerve sheath diameter. We can diagnose whether it is raised ICP or not. This method is 3 mm beyond the optic disc. We have to measure the optic nerve sheath diameter. It is more than 4.5 mm, then it is suggestive of raised ICP. It is very important in OT also. If we can use whether it is how much ICP. Also in casualty, whenever patient received, we can see whether optic nerve sheath diameter is more or less. We can diagnose whether need of a mannitol, how much mannitol. It is very handy tool in treating the patient day by day in casualty, in also OT. This is so much important. And the fast, the most important. Whenever patient received in casualty, if fast is not available in casualty, then patient have to shift in radiology department. Patient is unstable, patient is on inotrope support, so much difficult in stabilizing the patient. When emergency physician using the fast, e-fast in casualty, then diagnosis will be much easier and handy. Patient should not need to shift the radiology department long pathway and the long time. Time is important in trauma, that is we have to treat in patient in golden hour. So then the fast component are 4, and we have to extend the For E-fast, there is 2 point of lung scan also. We already discussed lung point, that is a barcode sign, seashore sign. So then is one more thing is refractory VT. Sometimes we give amidron, we give a lot of drugs for VT, but patient is not settling down, and 2 times, 3 times patient is going again and again VT. We use amidron, lignocaine, all drugs, but on that time the stellate ganglion block is so much important because refractivity has no treatment if that is not responsive to lignocaine or amidron. That stellate ganglion block can definitely providing help at that time. That is so much important. So the message is the in OT and beyond OT, we are emergency physician, we are perioperative physician, and we are anesthetic. We can use USG as a handy tool, and we can help the patient in as early as possible in golden hour period, and definitive management and diagnosis is so much important in that time. Thank you all.
Well, now I'll be sharing a few MCQs and then we'll move to discussion. Actually, we had a very brainstorming presentation. All must be very tired. So after these two MCQs, I think we'll have some discussions, if any. So what we have tried in this presentation is the role of USG for anesthetics, whether it is working in OT or outside OT. Believe me, USG is a very wonderful development for anesthetists. I don't know about other faculties or other branches, but as far as anesthesia is concerned, USG is a wonderful addition in our armamentarium. So I would request all people, all PGs, don't limit it to the classroom or question bank or question papers. Come out of it and start using USG and be equipped with the knowledge. Okay. So now we shall begin with the MCQs. This is what is the primary purpose of focus in a clinical setting: to perform in-depth imaging studies, to guide emergency surgical procedures, to provide rapid bedside assessment of diagnosis, and to replace traditional imaging modalities. Answer.
Ma'am, we have already responses, ma'am. All are responding C.
C. Fine. Next. Which area is specifically added in the E-fast exam compared to the traditional fast exam? Pericardial space, pleural space, hepatorenal space, and subxiphoid space. E-fast and fast. Answer is?
Mixture of A and D are present, ma'am.
Oh.
I think it is pleural space. E-fast. Just for lung, no? Anyways, that hardly matters. I would like to give a feedback from the PGs, what they think about this session, whether it has been useful to them, whether it was painful for them, or your opinion matters a lot. The whole purpose of exercise is failed if you are not satisfied. Okay. So, Dr. Bajwa.
Ma'am,
Yes.
we'll go to the questions in the chat box. Varsha, just address the questions in the chat box. All the questions have to be answered.
How many questions have been answered?
I have answered the question.
Most of the questions have been answered, I think.
Anybody has unanswered questions, please take up that question.
Please. We are open.
Presently, no queries have been posted, ma'am.
Anybody has raised their hands, just check.
We are open for discussion. Anybody can.
I don't see any raised hands, ma'am.
No questions?
Means everybody have learned
Or
everything about blocks.
no, even I think it is not possible to learn everything in one class, but what I feel, even if we have been able to make you sensitive regarding USG, my purpose is solved.
Dr. Varsha.
Yes, sir.
Is it satisfied with the answer? Have you understand that you have asked the answer question now?
Yes, sir. Yes, sir. We have understood, sir.
Understood that thing?
Yes, sir. Yes, sir.
So basically, just identify the humerus head and put the
Yes.
probe there, go downwards and identify that triangular fascia. Okay.
Okay, sir.
And
Yes,
then
sir.
go from cranial to caudal and intern approach and just pierce the fascia and deposit the duct there. That will block
Okay.
only axillary duct, not all the terminal branches, but we are blocking in brachial plexus block. Okay. So that is the
Okay.
advantage of that block.
Yes, sir.
So we can put costoclavicular block plus axillary duct block both for the arthroscopic surgery or fibrous nail.
Okay, sir.
So it will okay.
Yes, sir.
Okay.
We have
Can I-
one raised hand, ma'am, from iPhone.
Yes, madam.
Can you show gastric ultrasound, please?
Hello.
Can you show gastric ultrasound? How
Ah,
does it look?
did we cover the gastric ultrasound in this? No?
Yes, I think Dr. Nagal told some
Yes, yes,
points, ma'am.
yes.
Ma'am, we have
Yes.
covered the e-fast, not the proper
Gastric ultrasound.
gastric ultrasound. We covered the abdominal ultrasound, that is e-fast procedure.
Short of time.
Because there is short of time, there will be
Yeah.
long lecture if
Yes.
in specifically gastric ultrasound.
We can have a separate class on gastric ultrasound,
Yes,
actually.
yes. It is very important for pediatric patients.
Okay.
Am I audible?
Yes, ma'am.
See, gastric ultrasound is very important, especially for the pediatric patient, and it needs to be a special emphasis actually. And it is very important for pre-anesthetic fasting status and even many other investigations. So, since we were short of time, we did not emphasize much on this, but definitely it is very important. I agree. Thank you, madam.
We have one raised hand, ma'am. D3 Mohan Bag. Can we mute him, ma'am?
Yes, Dr. Manmohan Bab.
Unmute, sir. Unmute yourself, sir.
Okay. Okay, madam.
Hello.
So you're not audible.
Hello.
So you're not audible.
Madam, what a PNDT Act, madam? Hello.
PNDT Act.
It is. Hello.
Hello.
Madam, what about the what about the PNDT Act, madam? In that.
See, before getting a notification for pain clinics and for USG noti, we have to give an undersigning statement, because in our institute we have given it to the judicial magistrate that we will not be examining any pregnant lady, or we will not be doing any other procedure except for pain procedures. You have to give it an undersigning as far as government setup is concerned. If you buy an individual USG machine, I think PC and PDT Act definitely applies to it.
In government, you have to give the undertaking.
Yes, yes, it is through our superintendent or our radiology head that we are having an USG machine, and we are exclusively doing pain procedures and no other intervention. We have to give an undertaking.
Okay, madam. Thank you.
Ma'am, we have a query in the chat box. Do you suggest nerve block needle with the USG guided blocks?
Nerve
Okay.
block,
So
needle,
you
USG
do
guided.
any other cases? Oh, okay, madam. Thank you.
Okay, okay. हाँ बोलो.
See, what we are using in our setup, we are using TNS needles. 2 inches long needle and 4 inches long needles. We are using that thing. And if at all we have scarcity of that needle, then we can use that IV cannula needle. You have to blend that tip, and then we can use that needle also. Even that by that catheterize, you can catheterize the patient also. You can put the catheter by that PNS needles, and we will do continuous analgesia for that. So best thing is we ideally use PNS needles. So because it will be blunt, and non-traumatic needles are there. And if at all it's not available, then you can use IV cannula needles, but you have to blend that tip so that it will not cause damage to the nerve. Okay. Means Sudha Devedi ji, Dr. Sudha Devedi.
Yes,
Hope I
sir.
will clear the doubt. I have cleared the doubt.
Yes, sir. She's cleared, sir.
Okay, thank you.
No more queries.
No queries have been posted in chat boxes, no?
Madam Kavita Jain ma'am was saying about the revolution the USG has brought in anesthesiologist and over the last 15 years to 20 years. But in fact, it's not just anesthesiology, ma'am. If you go to the emergency medicine,
Yes.
if you have to go to the gynae departments, many different type of modalities have come up
Yes.
with the increase in resolution, then the digital format, 7D ultrasound. So many things have come up actually, and they have, and especially in the hand of the radiologist, the life has become easy for them for the diagnosis and interventions. So intervention radiology has advanced like anything over the last
Yes.
1.5 decade. So it has done a good job for almost every specialty, but definitely it has given wings to the anesthesia with the ultrasound and enhanced. I think very soon you will be using those enhanced features of the ultrasound, where the things will be just like you are seeing the real picture inside. See through and through that. That time is also going to come, I think, another 2-3 years, because we will be utilizing that, barring the restrictions posed by the PNDT Act in different states. But again, that is also, I think, with the time when the medical sciences will advance, the government policies will also be changing. Things will definitely enhance the popularity of the USG. It is going to stay, it is going to improve, it is going to enhance the skills of every anesthesiologist. I think for the pain physician, it's the best tool to have, best tool for a pain physician to have the ultrasound with the, because the blindness, the precision has increased, the accuracy has increased, and you are almost matching any other specialty in relieving the clinical symptoms of a patient, which is almost refractory, especially in the chronic pain patients. Blocks are really helping, and precise blocks are really helping a lot. And moreover, in the critical care also, ma'am, you are using it in so many areas, you are using it. Right from the chest ultrasound, you are doing it, the airway examination, you are doing with ultrasound, the cannulation, you are doing with the ultrasound. It has got applications in so many things. Even you sometimes the flow, the arterial flow, the venous flow also you can see during the critical care patient in shocks. So this is really enhancing the skill level of knowledge of anesthesiologist. And considering that, I have to do one thing more. Is the screen visible, ma'am?
Yes, yes, definitely.
So, Kavita Jan, ma'am, actually, you've done a wonderful job in at least starting this series of pain, because the pain was untouched in this classes of ISA online PG classes.
Okay.
So we have started it, and then definitely there will be many more chapters and classes will be coming on the pain. So thank you very much, ma'am, for preparing your team for this
Thank you so
beginning
much.
of the real class of pain.
I'm thankful too for patient listening.
Yeah. And Dr. Vikas, he was very elaborative in his talk and giving all the intricacies of the placement, the role of ultrasound, and thankful to him as well as Dr. Nagal also. He equally good. So both have done a wonderful job.
Thank you, sir.
Yeah. And Chandrakant, the PG student looking, I think, a PG student's presenting the thing on a pain. I think with the pain specialty, soon you will be having the DM in pain in India. That day is not far. So I think it's better for a PG student to prepare themselves if they have interest. Tomorrow, rather than just a fellowship, they will have a DM course also in the pain medicine. Thank you, Chandrakant.
Thank you, sir.
And Dr. Varsha R. Kalkani, she is a senior resident under the moderatorship of Dr. Madhuri Kurdi. She's a senior resident in her department, and I think she's done a wonderful job, enthusiastic person. And
Thank you, sir, for giving me such an opportunity, sir.
And moreover, thanks to Dr. Madhuri and Dr. Ridhima, they were coordinating with the class people how to prepare the technical thing. Those are very, very important. You have to have patience. You have to spare time to prepare everything. Be thankful to them always. Anybody wants to ask certain queries or questions, they can always ask before we close down this.
There is one query, sir. Should we obtain consent for using USG?
See, not for USG, but for any procedure, you have definitely to inform the patient thoroughly, take the consent, explain him regarding the complications, advantages, disadvantages, so that the patient should know what to expect and what not to expect from the procedure he is undergoing. Right?
The only tricky part here is the consent is regarding when we're going for a USG blockage of abdomen in anywhere near abdomen, and that too in a female patient who is in a childbearing age. And so in that thing, I think the consent, not just the consent, you have to write a documented, fully documentation, because the PNDT Act restricts you in doing those things. So it's a very special documentation you must be making when you are putting a block in a childbearing age female, and especially the abdominal block. So I think there the documentation has to be a little different. Already the Indian Medicine, this one Institute of Law, they have come up with a new consent form. So these things we have already added there. This one regarding the PNDT Act, as well as the obtaining the consent from a childbearing age female. Whether it's because we never ask the history. You know, in anesthesiology, it's a typical, we never ask the menstrual history or something like that when we start doing. Even the PSC, everywhere it is not written, you know, in every PSC, but should always be asked in such cases where you are going for a blocks or for an anesthesia or surgical thing. That point has to be added the way we have to add it in our undergraduate classes. Anybody else want to add or ask something?
So can I add something?
Yeah, you always should add. You are the moderator. You have to add.
No. Just, ma'am, you all have given an excellent presentation on these blocks. This is only for the postgraduates, that very often in theory paper they get a full question on one particular block, say quadratus lumborum block, write a short essay like that. So that time they should write it under particular headings. So initially we used to just write the anatomy, but now we should write the sonoanatomy as well.
Sonoanatomy. There is a word like sonoanatomy.
Yes, ma'am. So you start from that anatomy, the sonoanatomy, and then you go to the indications, then the probe, the resolution of the probe, the type of probe,
everything,
and then go to the technique, and then the whatever the complications and the drug volume and concentration used. So many of them, they directly jump on to the technique. That should not be done. So you should go stepwise when you write the note.
This is really important.
Block. This is only for the postgraduate students to get good marks. Yeah.
But
and then you can draw diagram also, a neat diagram of the
diagram, plus they must learn to practice the diagrams and sonoanatomy pictures by black and white statements. You know, it's not necessary you give only a photographic pic. You can give a ray diagram as well.
Yes. And that is seen on the digital image where the examiners use for checking. So this is very important.
One thing more you can add, Dr. Madhuri, in this thing.
Yes, sir.
For the postgraduates, when you are practicing these things, when you are describing this thing, do write at least 2 to 3 sentences about the communication, a continuous communication with the patient. If the patient is awake, we are putting it because that is the where you really learn the sympathy and empathy of doing the regional anesthesia. So that is a very important part. There, from there, they learn the basics of communicating with their own patient. The patient recognizes you. The patient gives you the respect later on also. Rather than just treating the patient in a way that patient is there, I just want to put a block. A communication establish a very good rapport.
Yes.
Suddenly silence.
Anything else?
No more questions.
There are no
Then
more
I think
queries, sir. That works.
I think we should then close.
Whenever you do local anesthetic.
We should close the class
Well,
then.
today we had covered acute pain, pain in OT, pain outside, in emergency, role of USD. There are many other uses of USG which these people might love to do, like chronic pain, cancer pain, trauma pain. So USG is vast, immense, no boundaries. So be motivated for USG. That is my carry home message, whatever it is.
Sir, can I ask you one question?
Yes, madam.
Hello?
Yes, madam.
Madam, can we mix two different local anesthetic together, like as lignocaine, adrenaline plus bupivacaine? Or should we restrict only to one reagent?
See, regarding adrenaline, we have to be very careful. Baki, we can mix, we do adjuvants also. We are adding adjuvants also.
Yes. But should we mix LDR, lignocaine, adrenaline, bupivacaine together?
Bupivacaine and?
Lignocaine, adrenaline.
Lignocaine and adrenaline 3 means a coction. I don't think...
2% LDR plus 0.5% bupivacaine. Can we mix them and then add adjuvants to it, or should we restrict only to one agent?
See, adding adjuvant is no issue because it increases the absorption, local action. But adrenaline, because once you are going near vessels, deep penetrating, you are sure that you will reach near vessel. So adrenaline may be very tricky because you are going deep down near the nerve. Vessels are already there. Maybe Dr. Baja would like to add something.
Yeah, ma'am. Actually, what happens whenever you are using blind technique also, you are aspirating the things just to see that doesn't go intravascular.
Yes.
Whether it's a venous or a capillary, whatever it is. Ultrasound doesn't provide you a safe platform or a where you can easily go with any needle and say you are seeing the black, blue and a red thing, vessels, vascular flow, whether it's arterial or a venous. It's not a guarantee. The ultrasound is not giving you a guarantee that you can easily mix adrenaline with the local anesthetics and then inject it. The risk remains the same. Ultrasound is not going to obviate that risk. It's a practice how you really inject. Sometimes when you are injecting it, it can go into the vascular space, although initially you are away from those vascular spaces. But injection can always go, even with the blind technique, the incidence almost remain the same. Even if you're going for the research academics, you see the research article on these things. Ultrasound does not provide you 100% guarantee that you will not be invading the vascular space. But definitely over the blind technique, it helps you. And then I think in the hand of the experienced person, it's a better, then you can easily use adrenaline. But I think for the beginners, it's better when you are already using ultrasound, you're almost going to the planes, you are almost going to the vicinity of the nerves. I don't think so. Then you have to use those things. You can, even the studies have come with the catheters also, placing the catheters in right place. You can use an infusions also later on after placing the catheter with the help of ultrasound. So ADR we are just using for enhancing only for 1 or 2 hours extra as compared for the local anesthetic action. So that can be taken care of by placing a catheter, or you can rightly inject to the right space. That will also lead to enhanced action.
Sir, another thing about the adjuvant dexamethasone, it is said that it is neurotoxic. So can we, instead of adding into the peripheral nerve block, can we give intravenous? Does it prolong the action? That's what.
There are many studies, ma'am. Actually, if you see the dexamethasone, always these steroids having an adjuvant role, there are mechanism of action, the nerve stimulation, whatever process you want to achieve. I think we can have a better adjuvant which can go if you want to give the IV. There are better drugs to go for that. Only thing is availability and how comfortable you really are. But even in the research academics, dexamethasone definitely do enhance to some extent. I don't think so that you have to do the research academics with adding dexamethasone than another drug there. It's all your comfort level. And IV will has a different mechanisms. The neural mechanisms are different, man. The ports are different.
Sir, in our setup, we are adding dexamethasone daily in our blood. It will enhance that effect of the blood.
Yeah, many places people are using it. Many places.
4 mg dexamethasone is enough for that like
Actually, it's not that drug which I think which you always being dreaded of. It will cause some toxicity immediately when it gets absorbed. So because when you're using a drug which you can use IV, so that using that drug for the as an adjuvant is not a problem. The only thing is regarding the regular practice of using it when we got our better alternatives to it.
Yeah.
Which other adjuvants you prefer, sir? Dr. Vikas Gupta, sir?
We are using dexamethasone in the dark blocks. And
apart from that,
and dexmet. 1 microgram per kg dexmet or 4 mg dexamethasone. We are using these two adjuvants you totally in our practice.
Dexamethasone is every route has been utilized in the world globally. Every research paper has been written. The only thing is direct into the brain, injection into the brain direct. That is the only route. Otherwise, it has been utilized.
Sir, if we are giving blocks by USG, so we know, sir, how near we are to the drug. So how we are injecting the drugs.
I think just like the ultrasound made a difference, dexmedetomidine has also made a difference, not only into the clinical practice, but in the research also.
Yeah.
It has given platform to so many researchers across the entire nation that almost everybody is coming out with the studies on dexmedetomidine, different routes, different doses. Yeah. And still, if you ask anybody, come on a stage, say convincingly that how much dose you really want to add here, nobody will come out with a conclusive dose, I'm telling you. Yeah. It's that wonderful drug, which still has a wonders about it.
But sir, main advantage that I have seen by using dexmedetomidine, the patient vitals will be very stable in doing the procedures.
Stable, sedative, cooperative. Because we I used to do these surgeries in 2008 and 9. When the drug came new, we putting the drug dexmedetomidine epidural only, no spinal. Urology surgery, the invasive urology surgeries, patient in a different lateral positions, so comfortable they were, and we published those papers also. But slowly and slowly, we have come out with so much good modalities that dexmedetomidine, doesn't look like you should be using in every route. So that is the one thing. But I think wherever you are comfortable, patient safety is the most important factor whenever you are using any drug. Just can't use the drug for experimentation or adventure, something like that.
Yes, sir. Right.
Okay. Thank you, sir. Okay.
I think it's 8:40 almost now. We should be taking leave from this classroom and meeting the next on 8th of July. So I'm thanking again to Dr. Kavita Jain and team, Dr. Vikas, Dr. Nagar, and Dr. Chandrakant, and to my colleagues, Dr. Madhuri, Dr. Redima, Dr. Varsha. And I think we will meet again next time. And then
Definitely,
I think,
sir. Definitely.
Yeah.
Thank you, sir. Thank you, sir.
Good night.
It was a nice experience for us too. Thank you so much.
The class will be.
My question not answered.
Which one?
Who's asking the
Sir,
question?
Raghunathan sir is appreciating it's a great class and truly inspiring. And he wants to know that GE has developed using USG with the AI. Do anyone has used it? He is asking.
I have.
So Raghunandan, develop a protocol for a research on, the use of USG and AI. I will be participant to that. You involve me in that project. Okay, then we will answer this question. I'm not going to answer anything on AI because AI is still in an fancy stage, even in the research. But you develop a protocol, we will go together for that. Okay, so
Yeah, sir.
good night, and end by saying long live ISA.